All right, let's dive into a really core topic in cardiology, the atrial septal defect, or ASD for short. So what is it? Simply put, it's a hole in the wall, the septum, that separates the two top chambers of the heart, the atria. It might sound simple, but understanding this one defect is absolutely key for your clinical practice. But before we get into the nitty-gritty, let's kick things off with a clinical puzzle. It's a real head-scratcher. How can a simple hole in the heart, something that can be totally silent for decades, how can that suddenly cause something as devastating as a stroke? It seems unrelated, right? Well, stick with me, because the answer uncovers some really elegant but critical physiology. Okay, so here's how we're going to break it all down. First, we'll see how the atrial septum is supposed to be built. Then we'll talk about what goes wrong with the blood flow. That's the shunt. After that, we'll jump into what this looks like in a patient, how we diagnose it, and of course, how we manage it. And we'll wrap it all up with a super high-yield recap for your exams. All right, first things first, to really get what an ASD is, we need to go back to the beginning, back to embryology. Let's take a quick look at how that wall, the atrial septum, is supposed to form in the first place. Okay, so this whole process is actually a really elegant four-step dance. Step 1, a little wall called the septum primum starts growing down, but it leaves a small gap at the bottom. That's the ostium primum. Step 2, another wall, the septum secundum, starts growing right next to it, leaving a different hole called the foramen ovale. Now, this hole is super important for a baby before it's born. But then, step 3, the baby is born and takes its first big breath. Boom! The pressure in the left atrium shoots way up, and it pushes that floppy septum primum right up against the sturdy septum secundum, kind of like slamming a door shut. This seals off the foramen ovale. So an ASD is basically what happens when something in this beautiful process goes wrong. So what if that door doesn't slam shut? What happens when that hole sticks around after birth? Well, that's where we get to the heart of the problem, the core pathophysiology, what we call the left-to-right shunt. Now, not all ASDs are created equal. There are a few different types, but look at this chart. The one you absolutely have to know is the ostium secundum type. It is, by far, the most common, making up about 75% of all cases. If you're studying for an exam, this is a must-know fact. Let's dig in a little deeper with this table. So you've got your ostium secundum, the most common one, right in the middle. Then there's the ostium primum, which is lower down on the septum, and you'll want to associate this one with Down syndrome. Finally, you've got the sinus venosus type. This one's way up high, near where the big veins drain into the heart, and it's often linked with problems in how the pulmonary veins connect back. Okay, so we keep saying left to right shunt. What does that actually mean? Honestly, it's just basic physics. Think about it. After a baby is born, the left side of the heart works a lot harder, so the pressure in the left atrium is higher than the pressure in the right atrium. If there's a hole between them, where's the blood going to go? It's going to flow from high pressure to low pressure, right? From left to right. And that's it. That's your left to right shunt. And this shunt sets off a whole chain reaction. Let's walk through it. First, all this extra blood pours into the right atrium, while the right atrium and the right ventricle are just getting flooded. We call this volume overload. So what do? They stretch out, they dilate. Then all that extra volume has to go somewhere, so the right ventricle pumps it all into the pulmonary artery. Imagine doing that for years, even decades. Eventually, the blood vessels in the lungs get tired of all that extra flow. They start to stiffen up and remodel, and that leads to pulmonary hypertension, basically high blood pressure inside the lungs. Okay, so we've got the theory down, we understand the plumbing problem, but how does this actually show up in a real person? Let's connect the dots and talk about the clinical clues and how we actually diagnose this thing. You know, what's really interesting about ASDs is that most kids who have one have zero symptoms. They're totally fine. The right side of the heart is a real workhorse and can handle that extra volume for a long, long time. But it can't do it forever. Symptoms usually don't pop up until people are in their 20s or 30s. That's when they might start noticing, hey, I get out of breath a lot easier, or I'm just tired all the time. Sometimes they'll feel palpitations because that stretched out right atrium can get a little electrically cranky. But there is one clue on a physical exam, one sound you can hear with your stethoscope that is so classic, it practically screams atrial septal defect. If you see this on an exam, you should be thinking ASD. And here it is, a wide, fixed splitting of S2. Let me say that again. Wide, fixed, split S2. This is the money finding. It's what we call pathonomic. If you hear it, it's an ASD until proven otherwise. So why fixed? Let's break that down. Remember, the second heart sound, S2, is really two sounds happening back to back. The aortic valve closing, A2, and then the pulmonic valve closing, P2. Normally, when you breathe in, the P2 is a little delayed, But with an ASD, that left to right shunt is always there, constantly flooding the right ventricle with extra blood. So it always takes the right ventricle longer to pump out all that blood. This means the pulmonic valve is always closing late, way after the aortic valve, no matter if the patient is breathing in or out. That's why we call it fixed. So you hear that fixed split S2 on your exam, and you're pretty sure it's an ASD. But how do you prove it? Well, the gold standard for diagnosis is an echocardiogram. It's basically an ultrasound of the heart. With an echo, we can literally see the hole, we can measure how big it is, and we can even watch the blood flowing through it from left to right. It's definitive. Okay, so we've found the hole. Now what? The next logical step is figuring out what to do about it. Let's talk about management. Now, how we treat it really depends on the size of the hole. If it's a small ASD, we often just watch and wait. A lot of these actually close up all on their own within the first year of life, which is pretty amazing. But for the bigger defects, the ones that are causing a significant shunt, we usually need to close them. And significant usually means the blood flow to the lungs is more than 1.5 times the flow to the rest of the body. For the super common secundum type, we can often fix it with a minimally invasive catheter procedure. For the other types, like the primum or sinus venosus defects, it's usually going to require surgery. All right, we've covered a lot of ground. Let's boil it all down to the absolute must-know facts. If you remember anything from this explainer, make it these points. Okay, here we go. Number 1, the most common type is ostium secundum. Don't forget it. Number 2, your classic exam finding, wide, fixed, split S2. Number 3, how do you confirm it? Echocardiography is the gold standard. Number 4, what's a common complication in adults? Atrial arrhythmias. Think AFib. And finally, number 5, what's the dreaded late-stage complication? That's when the shunt reverses and the patient becomes blue. We call that Eisenmenger syndrome. So, if you had to sum this all up in one sentence, what would it be? Here it is. An atrial septal defect is a left-to-right shunt that overloads the right heart, and its classic calling card is that wide fixed split S2. Oh, and remember that question we started with about the stroke? Well, here's the answer. A tiny blood clot from, say, a leg vein can travel up to the right atrium. Normally, it would go to the lungs, but with an ASD, it can sneak through that hole, get into the left side of the heart, and from there, it can travel straight to the brain. That's called a paradoxical embolism. Thanks for joining us.